Welcome to ABA on Tap. I'm Mike Rubio with Dan Lowry. So without further ado, sit back, relax, and always analyze responsibly. All right, and welcome back to ABA on Tap. I am your ever grateful co-host, Mike Rubio, and this is part 2 of our interview with Dr. Tranika Jefferson. Enjoy.
Not involved, because there's a whole early, I think it's called ECI, early intervention, something as relates to that. Yeah. That if they're under 2.5, that they could get that without having an autism diagnosis, just early intervention, like skills training that they could get. And then most, from what I've seen, doctors will give the autism diagnosis around 2.5 here.
Yeah, that seems to be a pretty commonplace. The magical age of 3 for autism diagnosis, right? I like to think about that sometimes because it's very politically driven and it also makes sense. And then it's like, wait, well, what magically happens at age 3 that we can solidify that diagnosis? I don't think it has anything to do with diagnostics as much as payment.
The same thing that magically happens between 39 and 40 hours of surgery.
Oh, or I thought it was 19 and 20. Or wait, we'll get into that.
So you mentioned that the Medicaid can be a little bit cumbersome to get started, and that's all process. But how about the ongoing in terms of the dictation of services? Do you find that you're kind of able to do the things that you want to do and you think you need to do, or is there a lot of oversight and a lot of dictation of no, you can't do that, or it needs to be done this way, or I've heard that we're not vendored with TRICARE, but I heard TRICARE said that you can't do services outside anymore for some reason. How are you finding that in terms of the Texas Medicaid side of things?
Yeah, I'm a rule follower, so how I navigate that is I review the contract, the standards, so I know what's acceptable. And so I think that just comes with kind of educating yourself on each, vendor contract that you have. So you'll know okay, these are the rules and this is how I fit what parents' preference is and what I want to do clinically into what their rules are, and I make it work.
Very good.
One thing that I really like, and it's been a little bit of we've navigated it well, but it's the inevitable, challenge in ABA, especially with running your company, is most people want services outside of school hours. So, 3 to 7 or weekends, like you said. Most workers don't want to work 3 to 7 or weekends. So it's trying to find matching availability with having RBT base that is excited and wants to work and doesn't just get burnt out with the hours and the weekends and stuff like that. And I heard you mention that you do a lot of, weekends and evening hours, which we love. We love fitting in the ABA into parent schedules, not making parent schedules fit into our ABA. So can you talk a little bit about how you navigate that? And also, do most of your RBTs then have a daytime job or what does that look like?
Yeah. So what my RBTs look like is most of them have a full-time job or they're working towards hours. Okay. And so they're needing, those field work hours of hands-on working with someone. And so there's no problem with them working outside of their full-time job because they, may not get off work until 4:00 anyways. And so for me, their session with a kid may start at 5:00. And so it works out perfectly because I'm feeling a need that sometimes there's a gray area in the ABA field of people that are trying to accrue hours, but they can't just stop their job because they may not be working in ABA. They may be a teacher or just any other job, but they're trying to get hours for the BACB. And it's a struggle sometimes finding supervision and finding jobs that will be very flexible and, provide those hours outside of their full-time job.
Oh, interesting. So what kind of balance are you seeing or what's the distribution between the younger professionals who are gearing toward the RBT versus maybe older established professionals? You mentioned teachers who are now going back to add the ABA part to their credentialing.
You said what's the balance?
Yeah, how many of each are you seeing as far as your staff?
So I actually have one staff that has been one of my RBTs for some years now. She had been working towards her BCBA. She passed her BCBA this past Friday. So
congratulations.
Shout out to your new staff.
Yay.
To your new BCBA.
Or your newly certified staff, sorry.
Yes, but she's a psychologist. And so she had been, of course, she's an adjunct. No, she's not an adjunct. She's a professor at one of the colleges here in Houston, but she's been wanting to be a BCBA. And so with working with me, it worked out for her schedule because she didn't want to stop teaching. She loved teaching and she does that throughout the day. And so it made perfect sense for her to be able to take on one client to, of course, her bring in extra income for her to get her hours. And now she, could be a psychologist. She could teach at the university and she could do the ABA world. So it was, kind of double fold or triple fold beneficial for her with having this type of flexibility in schedule. In addition to, I've had an intern before, and also one of my previous workers was a speech pathologist. And so she was doing speech, her full-time job during the day, and then she was able to do ABA outside of that.
Wow. So those families that you're working with, they're lucking out. They're getting a highly trained staff, both with you, but also with somebody with a lot of skill sets outside of the field as well that knows how to work with kids.
Right. Yeah. All of my staff for the Behavioral Wellness Academy are, professionals that have been in their profession for years or decades that, didn't start out in ABA, but learned about it later on in their careers. It's like, oh, well, I've been a teacher or I've been an educational dietitian, but I'm really interested in doing ABA, but I can't leave my full-time job. Like I still need to get paid, but I don't want to work in an ABA clinic setting right now.
And was everybody that, in that role well prepared? I hate to put it this way, but it might feel like a step back for some people. You're an adjunct professor somewhere and all of a sudden you're playing an RBT role. Mm-hmm. What was your experience with that? Did anybody have trouble with that, or were they all pretty well prepared and enthusiastic about taking that step?
I feel like their coursework when they were working towards their master's degree prepared them for that aspect. So they kind of knew what they were going to get into already. And I don't feel like they thought of it as a step back. I feel like they thought it was basically the road to get them to where they wanted to be. It's like, okay, well, I will be an RBT because I know that that's going to get me to my goal of being a BCBA.
I find that probably prepares folks a little bit better for the hands-on supervision aspect of the job. I feel like a lot of, this may not be the mainstay, but a lot of younger professionals, the idea that if you're an RBT, your only career path is to then work up to your hours and, be a BCBA. And then once you're a BCBA, maybe a lot of people have this idea that now you're managing and you're supervising and the hands-on part goes away. But that might be different in your experience. These are people who want to go back to that hands-on part in order to gain this experience.
Yeah, that has been my experience. They want that hands-on learning because what I see in our field is a lot of people, they really want that supervision. They really want that mentorship. They want to know what to do. And they know a lot of that comes with just doing it hands-on themselves so that they can eventually be a really good clinical director or a really good, supervisor to the people that, they're overseeing.
I feel that's super important. I think that's just makes such a difference. And I say that just in having started at operations, 16 months ago for our brand new project here, Ascend, I took on the role of doing the direct service. And in that sense, having been a BCBA for almost 20 years and having supervised casework, but now for our company saying I'll be doing the direct services. And it was, it was working up some endurance at first. It was getting my chops back a little bit because I hadn't been actively practicing it. And, after a good 6-8 months, especially now, I'm almost fearless, I would say. I'll walk into any situation and do direct service. And I do feel that that's been of benefit to some of our younger professionals who are RBTs, who have had other clinical experiences or, we commonly hear, I never see my supervisor. I see them once a month. And it's like, you're going to see me at least once a week. And, we're going to have to coordinate and collaborate so that I can jump in and show you something and then you can demonstrate. And it's going to be a very active collaborative effort. So, and again, to echo what Dan said, your clients then are getting super high level service with quintessential professionals who have a slew of experience, a wide range of experience, and are now able to directly interact and provide the treatment. That's remarkable.
Yeah. We enjoy it all.
And where do you find, so, I mean, that seems like a pretty idyllic situation with people finding you that can mentor them and give them the hours that they're looking outside of so they don't need the 40 hours from you, the 40-hour work week from you. They need maybe a couple of hours on weekends or in the evenings. And then you get the benefit of not needing the daytime hours, but also having a pretty big skill set and moving forward. How do these people find you, or how do you find people? Like, because I feel like that's something that we should probably look at as well. Here in California,
I knew where you were going.
Don't worry, we're not going to Texas. Yeah. How do you find these people, or how do they find you?
Yeah. So for one, I'm in like all of the social media ABA groups. And so
those are dangerous.
They can be.
Are they really?
I hear the parent ones are.
Oh, okay.
The anti-ABA parent groups, yeah.
I'm usually not, I don't like post in the groups, but I read like everything. And so typically at night, once my night starts to wind down, then I just go on my Facebook and go into any of the groups and just kind of stroll. Some are educational. I learn a lot of information. Sometimes there's debates and, all the things that could go on. But sometimes people, of course, a lot of times they put in those groups that they're looking for a supervisor. And so sometimes I may reach out like, hey, this is what I have available. And, is this something that you would want? Or people inbox me from following my pages on social media, or they may have worked with me before and they may reach out, like work with me at a different like agency, and they'll reach out like, hey, I know you're doing your own thing. Do you have anything available for me?
Nice.
Because I do have like one employee now. She's followed me throughout the years, wherever, I'm at or whatever I'm doing. Like she was like, okay, I want to work with you.
Nice connections for sure.
Yeah. And just like people just know me in general from, social interactions, ex-boyfriends or those type of things. And like, oh, I remember meeting you via X such and such, and I know you do ABA.
Saw you on the news. Talk about that in a minute.
Or they seen me on the news or some ABA, platform. So that's usually how I get my, current staff.
Excellent. So I imagine you also have younger professionals or RBTs on the younger end who are embarking on their first master's program and looking for their hours. Is that fair to say?
Yeah. So at my actual clinic at CODA, I have 2 RBTs that are working on their masters and that are accruing hours with just working there full time.
Okay. Maybe talk to us a little bit about the difference between maybe some of these more experienced professionals who are coming back and doing the ABA coursework and working as an RBT versus the younger ones that are building up. What do you find are unique struggles for the younger RBTs? What has your experience been in terms of, really bolstering those younger professionals and everything from their work ethic to, their study habits to their timeliness at work? Talk to us a little bit about that, because I know that can be, I'm sure that's a contrast if you're having an active, adjunct professor somewhere who's now doing coursework and to get their hours and they go back to an RBT. That's going to be a different work ethic or level of experience altogether from, a younger 20-something who is, getting their bearings.
Yeah. And I mean, I could even just remove the whole ABA component outside of it in general, because I think this could function in any work environment, the conversation.
Yeah, you're right.
From what I've seen is just a level of professionalism that sometimes is the differentiation. And so I talk about this a lot at my clinic as it relates to sometimes when I even interview some people now, it's like, when I was 20 or 21 or 25, like I would never go to an interview, like wearing certain things or saying certain things. And just sometimes the demeanor, I guess because I am the older or vintage top shelf professional.
I like that.
Just from even in college, like it was a class where they trained us, like, this is how you dress for an interview. Like, this is what you wear. This is how you, the do's and don'ts, like, don't do your hair like this. Make sure you do this. Like, this is what you bring with you. As opposed to, I think now the younger generation, something like, I don't know, a lot of them aren't learning that skill set as far as just like basic professionalism. And so I've had like interviewees that come in and like some women, I could see their bra strap or they may have on tennis shoes. And it's like, who's training these people? Like,
Yep.
And like, the basic things, or like even things not to say in an interview is like, don't talk to me like you're my homegirl. Like it's
Not yet.
too friendly right now.
What if I told you that one of our last interviewees showed up with no shirt on
Over Zoom? Of course.
showed up late with no shirt on, and then like iPhone camera? Just like, it's
It was
an interesting world these days.
It was a first. It was a first for us. Like, wait, he's not wearing a shirt? Okay. I mean, I guess it's comfortable in your home Zoom interview, but you could put a shirt on, I think.
But what would you say after? So I hear you, because we do the hiring too, and it's or just ghosting. Like, people will stop talking to you in the middle of the hiring process or something, and it's like, are you taking the jobs? Like, what's going on? But how about once they get onboarded? What differences do you see between the RBTs, maybe at the Wellness Project, with the ones at CODA, both pursuing their masters? Do you see a lot of differences once onboarded as well?
Sometimes there may be a difference in like punctuality and like, oh, you didn't go to the session and the parent was waiting on you, and you was like, oh, well, I forgot, I fell asleep, but you didn't think to let anyone know. Like, that's not okay.
Yep.
My older, staff would never. But you like see no problem with like showing up late or leaving early, or just the communication aspect is sometimes not well.
It's interesting
from what I've seen.
Do you find that one group tends to be more like flexible in terms of your suggestions, and other groups tend to be more like, nope, I'm going to do it this way? Or, willing to try things, willing to stick it out? Or do you not necessarily see that from one group to the other?
I haven't personally seen that from one group to another, but I know it happens. What I've seen more so is relates somewhat to that, not as it relates to age, but people that have worked in a lot of different ABA agencies or organizations. And it was like, oh, well, this is how we did it there. Or they're really stuck on the DTT, when some of us in the ABA community have moved towards the Ascent base and the trauma-informed base.
Yep.
And that learning curve from doing DTT at 5 other ABA agencies, sometimes that's a huge transition to doing more Ascent-based. Yeah. It's like, well, this is how, so you mean like I can't hand over hand with them? Like, but when I work for this company and that company, like, this is how we did it. And I'm like, well, that's not how we're doing it here.
This opens up a whole nice topic of conversation here. So I'll start with this question. You got to see a lot of people do things differently. You still know that other people running other agencies are doing things differently. Give us your top 3, pet peeves or things that you saw before you were running your own show that you said, when I do this my way, when I have my own way, I'm going to change this, that, or the other. What were some of the things that really, got to you or bothered you, or you just weren't comfortable with when you were working under somebody else that now you get to do your own way?
Number 1 is forcing the 40 hours a week when it's not needed.
Amen.
And I think that's the ethical part of me. Like, I hate when I get an ABA referral, because to even go back, the ABA referrals are written. The doctor writes on all of the referrals, like up to 40 hours of ABA a week. So we get the parent, and the parent's like, well, the doctor said that they can get 40 hours of ABA. So I want my kid to have 40 hours of ABA. And I let them know, like, okay, I'm going to do the, assessments, and whatever I clinically feel like is a medical necessity number of hours, that's what I'm going to recommend to the insurance company. Your kid may not need 40 hours, and I'm not going to do 40 hours or have my staff do 40 hours, and that takes them out of school. And so now they're not learning academically, and they're in ABA for 40 hours out the week, when they don't need to be in ABA for 40 hours a week. They may have, level 1 autism. They may just need to work on social interaction skills. That doesn't require 40 hours, and that doesn't require them being taken out of school to do ABA full time.
Yeah.
And that's my number 1 rant.
Okay.
We're going to go on to number 2, but is it just from that original Lovas article? Where are these pediatricians or doctors getting this from? Is it because we impose that? Where do you think they're getting, or they're setting that standard and perpetuating it?
I'm not for sure. I don't know where the doctors got the 40 hours. I don't know if that was like the initial like insurance cap on how much they would pay out for ABA, or from a clinical standpoint, it may have been said that the most beneficial, I guess, 40 hours would be what someone needed. That may have been like, very severe autism or behavioral needs, that like, 40 hours would be the magic number for most success.
Yeah.
So I'm not really sure on that. But one of the things that, along with that number one thing that I hate, is some ABA companies, they will basically not admit some kids if the parent, can't do the 40 hours. And so, because they're forced, they want to get paid.
That's our personal favorite. That's our personal least favorite, I would say, is when we get the calls and people are, so do we have to do 30 hours a week for you guys to accept us? Like, no. I don't think we have anybody at 30 hours currently, or anywhere even near.
Anybody at 20.
Yeah. But that's interesting, because you mentioned something very important, and I can get very critical about this. I don't want to go there, but I think it's an important discussion to say, yeah, of course, in terms of your logistic, your scheduling, it's very easy as a business owner to say, hey, 30 hours is what we recommend. 30 hours is what you get. We've got plenty of empirically valid research that'll say 30 hours is good and 30 hours gives you good outcomes in terms of ABA. And then there's the stuff that you're talking about that I think we embrace, which is, hey, people have lives. Kids have to go to school. How do we fit that science-based, that empirically valid treatment into their lives? Or like Dan put it earlier, instead of them having to fit into this mold. There's a lot to discuss there. What's your view on that? Again, it's very easy from a business perspective, because now you've got everybody nicely calculated. You're getting 30 hours. You're getting 30 hours. I can run my numbers, and everything looks good. And then that can really be strenuous. That can be overkill in many ways.
Yeah, it could be overkill. And then even if, you recommend and you get approved for that 30 or 40 hours, but then of course life and things happen, and maybe you're only able to do 10 hours because, whatever is going on with the parent schedule, or just anything in general that could happen now. And now you're at doing the reassessment, and you're having to justify, okay, why didn't these 40 hours, why didn't you utilize the 40 hours that you were initially approved for? And now you're requesting, 40 again. And the insurance company may deny that. Like, you underutilize, the initial authorization.
Yeah.
So we're not going to approve, that also. In addition to, sometimes I may see it clinically necessary for a kid to have 20 hours, but I always have the conversation with the parent, like,
interesting,
is 20 hours feasible with, them being in school and your work schedule? Because again, my staff for the behavioral wellness, they're doing sessions either in school or in home. So if they're doing them in home and the parent isn't home to do the sessions, it's like, okay, well, yes, they may need, 20 hours, but what are you able to do? Okay, you could do 2 hours, Monday, Wednesday, Friday, and then like 4 hours on Saturday. Like, what actually works for you? So I have those conversations up front before I even submit for the authorization.
That's interesting. I mean, even so, the time with which you deliver services might impact our recommendation if we're not careful, right? So the idea that we're fitting into the family's lifestyle, but we're also fitting into weekdays from a certain time to a certain time. So it's interesting you say that. I like that you mentioned that, the idea that I might be recommending something high level based on what I see as necessity. But again, going back to the question of how much can you actually access reasonably and within a comfortable level, so that it's also effective, knowing that we don't want the treatment to become overly taxing. That's not going to be fruitful in the end.
Right. Especially, a lot of times our kiddos, they're not just in ABA therapy. They may have speech, they may have physical therapy, they may have, OT as well. And so it's like, sometimes we're burning these kids out. It's like there's 40 hours of ABA, and then there's what speech does typically with the 2 hour, 2 days a week, 30 minutes. And then they may have OTs, like, that it may be a medical necessity for them to have, all these specialized therapies, but sometimes it is overkill.
Especially for pulling them out of their environments, like you said, school or something like that. I find it challenging to think about. I think a lot of the companies are, recommending, like Mike said, because of the business side of things, like more hours means more money. But then even, I think some people aren't necessarily doing it just for business. They're like, oh, well, it makes more services are better, like the parents are thinking. But the problem is, if it's just ABA services, then you're actually pulling them either away from school or away from being with their friends at home or things like that. And now they're getting 40 hours of this isolated services. So in certain ways, especially because socialization is one of the big domains, like it could actually, I feel like, make it harder to then reintegrate or generalize these skills into life because we're ungeneralizing them by pulling them out for so many hours out of the week.
Yeah, that's a good point as well.
What is what would be your viewpoint on that, knowing that there might be a reason to say maybe pull your child out of school to receive the services, and then that's different from, say, now a business model that says, well, hey, if this child who's under 5 who's going to get early treatment at the school under the IEP, they could just get that at our center. And those are two different approaches there, where one's business-based, one's necessity-based. What would you say would be something that would deem pulling a kid out of school for ABA services as a necessity?
Yes, I have this conversation a lot as it relates to if the kid isn't learning in school. I have this conversation more so is my beef with the independent school districts, that they don't allow us to go in and provide services, but the kid isn't learning anything anyways. So it's like, oh, well, because that'll take away from academic time. But the kid is basically running around the classroom, fighting other students. They're not learning anything that's functional there anyways, or academic. So if they're not learning, then I am in full support with them, of course, being an ABA and being in a structured environment that, can help decrease those behaviors that they may be having in school that minimize them from, learning effectively anyways. So that's when I'm all for, of course, the pulling them out of school and having them do ABA until they get to a point where, they have learned skills, the behaviors have decreased. So now we can integrate them back into school more. So I always feel like it should be some type of transition fading plan to integrate, the ones that are either in ABA full-time, to integrate them back into those social settings like the school and other places as well. So it shouldn't be 40 hours like every week forever. What's the plan to get them back? Their school age, they need to get back some way academically, even if it's, half a day, twice a week, whatever that looks like for that particular kid.
Thank you for lending that clarification. I mean, essentially, we're imposing a restriction in those situations. The idea that, you shouldn't be in school, you should be in this treatment. But at the end of the day, that could be a restriction to just normal daily life for a child. The idea that they have a right to be in school with other friends, but if that's not successful, then how can we pull them out and bolster them to put them back in? I think that's a really important distinction you lend there. Thank you for taking the time to do so. What do you find is the resistance for independent school districts in Texas to bring in outside consultants or ABA professionals to help? Do you have any idea on what might be happening there?
I'm not that well versed on the education side. From what I usually get from, just being a provider, is it takes away from academic time. The kid already has an IEP or a 504 plan, and they're, I guess, underneath the IDEA working on, addressing these behavioral issues. But what I get from parents is they're not doing, anything in the classroom to address these issues. The parents or sometimes unaware of what they're doing. And the kid continues to have, a high increase of these issues in school. And even the teachers, like, they're stressed out sometimes, but of course, it's not their call on if a kid's provider can come into the school and provide services.
So it's sort of a general notion that as ABA professionals, we're going to go into that setting and sort of isolate the student to run something a la discrete trial training. Is that kind of what I'm gathering from what you're saying?
Yes, pull them away from where they could be academically and as a provider, like, do a session.
Also probably worried about getting called out as a teacher. One, because maybe they're not following the IEP and then that doesn't look good. Or two, because a lot of the ABA providers, we know one-on-one, we don't know, 20-on-1 like some schools are. So that can probably be challenging as well. Nobody wants to get caught out in their own classroom.
Excuse me. I think part of our success, so we do a fair amount of contract work with school districts, as it were. It's probably a sector we're growing most in. And I think that's one thing, to your point, Dr. J, in talking about that fear of isolation. It's something that I think we've done very well with our staff and saying, you need to go in there and yes, you're assigned to that student and you're keen and focused on supporting that student, but please become a part of the general environment. Mm-hmm. The idea that our services should not be creating another small classroom within that classroom. Our effort is to make sure that we help that student integrate into the general setting. And there's other challenges that come up there in terms of the creativity and flexibility of those settings. There's already school rules and campus rules and bell schedules and a lot of parts of the environment that you can't change, which is its own unique challenge. But I do appreciate the fact that I think we've been successful with that idea of we're not going in there to isolate. Yes, we are assigned one-to-one, as it were, but if we're doing our job correctly, we're really integrating into the greater environment.
I got to hear number 2 and number 3.
That's right. Number 2 and number 3.
What were number 2 and number 3 kind of either frustrations with the field or things that you really kind of wanted to address with your new company? Or not new, but with behavior wellness when you did your own thing?
Yeah, I think one of the other main things is just providing the flexibility that, of course, agencies sometimes can't or don't provide. And that allows me to help other people that are, trying to be board certified, or maybe they don't plan on being board certified. They just want to take an RBT or a BT position to, help them out financially, or they don't want to go the full academic route, but they love working with kids with autism. They love seeing the behavior change. And so allowing that flexibility that a lot of organizations don't provide and giving people that chance to either more financially get stable or to fulfill a passion that they want to do or get them to their long-term goal with being board certified. And so that was another kind of gap in previous places where it's okay, well, I could help these, I want to help or do these certain things, but, I can't because this ain't my company. Yep.
I remember one of the very first companies that I worked at, I was the trainer and we had a huge turnover, and I brought that up to one of the higher ups and they were like, yeah, we don't really care if the RBT leaves or we'll replace them. And we were like, yeah, when we start our own company, we want to get rid of that idea. These are people that have good intentions and have various different motivations, like you said. And if we can cultivate their motivation, whatever it is, they'll just provide that much better of a service to the clients, which at the end of the day was our goal.
Mm-hmm. Yeah.
Yeah, continuity gets a little lost sometimes in that shuffle, and the idea that the RBT is expendable and replaceable. And we came in with the idea of, no, that affects continuity of services. When I go to the doctor, I like to see the same doctor if I can. And if the nurses are similar and they're familiar, that feels great. My dentist, I want my dentist. The idea that every time I go receive a medical service, I'm facing somebody new, brand new, somebody that just came out of training, that falls apart pretty quickly.
Mm-hmm.
Can you think of a third one?
I can't think of a third one right now. Those are my top 2 cumbersome things that I was yes, I definitely
walk you down a third one because it's something that I think we really relate to. And you've talked about maybe the transition from DTT-based, more structured or adult-led services to more child-led services. That's something we very much prescribe to. Our company is called Ascend Behavioral Solutions. It's a play on Ascent, which is, you mentioned as well, being more kind of naturalistic and Ascent-based. So can you speak on maybe your desire, your thoughts on doing a more Ascent-based approach rather than DTT? Because we very much prescribe to that as well.
Yeah, so I am actually I would say within the past year, switched over to more the Ascent model. And what I've seen it in action is sometimes our kiddos become more receptive to us, and they don't see it as though I got to go to the clinic and I don't want to be there. They see it as a place where, we get to play. We're on the swing in the summertime. We have a pool. We have a full, huge trampoline. We're a house setting that we've made into a clinic. So anything it's a house. It's, 8 bedrooms, your master, your backyard, your front yard. It's gated, basketball hoop in the front yard. This is, just another house that I'm going to play and have fun with my friends. It's cool. Not where this is a commercial property and, I'm in this classroom, I'm sitting at a table and I'm matching, different colors and things of that nature. It's I'm going another home to go to, I'm playing with my cousins. but
wow,
you don't know that you're learning.
Was that by design, happenstance, that you guys landed in that setting? Can you tell us a little bit more about that? That's remarkable. I mean, you're offering a very homely setting. That's really cool. But how does that's not very common. How did that happen?
Yeah, so that was the goal, was to find a place where, well, there's certain places that you could actually turn the home into a business. So it was strategic to be in a precinct area where you can have a home as a business, and finding a home that was big enough to allow us to run a clinic there.
That is awesome.
So that was the plan, as opposed to like, oh, well, I found this, this commercial space.
Well, then you get to build it out. I mean, I'm not sure what the parameters are. You can get into that if you like. But yeah, different from a commercial space in terms of the readiness, how it presents. It just seems to present a lot more flexibility with what you might be able to do, and just a lot more warmth, I would say, in terms of the setting. That's a really cool idea.
Yeah, and it definitely helps with the generalization because, most of the time we're trying to generalize skills to the home setting. So it's like, okay, well, now we're just generalizing from one home to another home, not from clinic to home.
And this is CODA that you're talking about?
Yes.
Oh, wow, that's so cool.
Amazing. Yes. That was ironically, the founder, president of CODA, she found me on LinkedIn.
Wow.
Okay.
And so I was completely happy at the Harris Center because, I was doing my little 1 hour, once a week sessions. I was content, not like my first non-stressful job that I had ever had. And so when she messaged me regarding that she was opening up a clinic, and basically I would have full range on anything clinical that I wanted to do, I was just like, oh, well, this is my dream. I never actually wanted to be in an ABA clinic. And my ultimate goal long-term was, if I ever do an ABA clinic, I would want to do a house that I make into a clinic.
That's cool.
And lo and behold, this person contacts me and was like, I found you on LinkedIn and
amazing.
I would love to have you for my clinical director. But I ended up changing my title. I was like, well, no, I want to be the chief clinical officer.
Nice. Wow, that's great. What a great idea.
That is so cool. So do you want anything you want to speak on the CODA piece? I know that's relatively new, about a year in, but that sounds like it was serendipitous for you. Anything you've learned or want to talk about, or want to speak to our audience about things that you found or words of wisdom from being at CODA over the last year?
Yeah, CODA, I mean, we're still a growing organization. I mentioned that we just opened in May. So basically over all things clinical, and the president, she typically does all things HR. So I don't have to do the HR and the payroll component. So it's a perfect, balance between the both of us.
Oh, great.
And we have about 8 clients that are there now. We have some clients that are waiting to get started. We're in the process of hiring more RBTs. I was on the news 3 times last year, of course, representing CODA and disseminating information out to the community from the CODA aspect. And yeah, we're assent-based, and then we also take into account trauma-informed care with doing ABA. We are strategically, again, placed in an area in Houston that did not have any ABA clinics within close proximity. And so we're in an area that, is primarily the Black and Brown community.
Okay.
And because, they need services as well. And there was, not anywhere that they could immediately get services that was close to them. They would have to, drive outside of their neighborhood to get services. And so that's another awesome piece about being at CODA, is we're catering to sometimes the underserviced community that typically have a lack of services or may not be able to immediately access them.
Sure.
And of course, we are in a neighborhood because, we're a house.
Nice.
And so we're easily accessible to the people that are in the community to be able to, come and bring their kids to, get the services that they need.
That is so cool. It's cool you mentioned trauma-informed care too, because you hear about some people talking about ABA experiences being traumatic. And I joked about the parent Facebook groups, but if you even talk about ABA, they're like, no, that'll traumatize your kid. Yeah. And it is interesting how there is that dichotomy about people that did have traumatic experiences, and certainly providers that did not intend to traumatize the people that were getting services. And I think what you're saying about the trauma-informed care is so useful in making sure that we don't perpetuate that. With CODA, so you mentioned that it's in a residential area. What is the ages, and then how long do people come to the clinic?
The ages is the youngest I have is 2.5. And the oldest right now is about to be 12.
Okay.
And so we're open from 8:30 to 4:30. Some kids may do a full day. Some may do a half a day where they either come in the morning or they come in the afternoon.
Awesome.
Wow. Okay. And no, you didn't. So, and is this autism specific diagnosis, or are you seeing different things as well?
Yes. So of course, all of them have an autism diagnosis. Some of them also have ADHD, which I see a lot.
Yeah, that's exactly where I was going. Given the demographic you're serving, I think there tends to be a correlation there. And then we talk a lot about diagnostic substitution here, because I know that's important for access sometimes. So kids might be experiencing other things, but if they don't get a certain label, they're not going to get access to good folks like yourself. So that ADHD autism comorbidity, talk to us a little bit about that. That's sort of a unique experience. I think it's very common. We see it a lot, but it might change the way you approach treatment. What's your viewpoint on that?
Yeah. So what I've seen is, again, to go back to how we function at CODA and more assent-based is, and of course, not being very DTT driven is, in order for you to learn a skill, you don't have to stay seated. Like if you want to work on gross motor skills and we're outside in the backyard on a trampoline, then that's where we're going to learn that skill. You may have different sensory issues that, staying seated is not going to work for you, in addition to having that ADHD diagnosis. So we're going to learn skills wherever we can learn them. We don't have to stay seated. We don't have to be in this, classroom. Nice. We're going to go outside, or we're going to be in the living room, sitting on the couch, where, you would do the same thing if you were at your home anyways.
Yeah, that resonates with us very, very nicely. We appreciate that very much. So talk a little bit more about you alluded to the media presence, and that seemed to be, to some extent a little bit of marketing in your effort, but has that gone beyond that? Are they accessing you for sort of content expertise? If certain things happen around town, are they reaching out to you to comment on those things? Tell us a little bit more about your media presence in Houston.
Yeah, I would love if they reached out to me, but at this point, I'm reaching out to them.
Well, keep doing that. They'll come back. They'll come back around.
Yeah. So what I've done is I have a full 12-month pitch deck. Every month, it could be a conversational topic as it relates to the autism community. And so I built this pitch deck last year. And so what I do is each month I email or I go on the website, whatever communication form that particular news station requires as far as submitting to be a guest on the show. That's what I utilize. And I give them my pitch deck, for that particular month. And, sometimes they bite, sometimes they, ignore, or sometimes they wait to the last minute. It's oh, can you come on tomorrow? Yeah, I sent you that 3 months ago, but yes, I could be there tomorrow. And so what I get a lot of times from not just my other ABA colleagues, but people in different fields, it's do you have a plug at the news stations? How are you always on the news? I was no, I don't have a plug. I just present information that I know is socially significant to a large population. And that's how I get to be on there.
That's great. That's great. So you sort of reached out to one particular outfit, and then, or did you have to reach out to many to grab a couple? How did that work?
Yeah, I reach out to all of them. All of them get the same email.
Okay. And
I just okay, well, copy paste to Fox 26, copy paste to, KPRC, copy paste all the other, news stations.
So you've got several that you're working with now, or have it only been a couple that have bitten?
I've been on 3 different news stations.
Cool.
3 or 4.
That is such a cool new frontier.
Yeah, no, and I like that. Again, I often make the joke, if you watch the news and there's something that happens, say, autism related, and then they bring on a content expert, and it's, somebody more traditionally in psychoanalytic treatment, or something that isn't somebody that isn't one of us. And it's come on, we got to represent better. So I'm really, really glad that you're out there doing that and putting BCBAs at the forefront where they should be, under certain content expertise. That's fantastic.
Yeah, that's the goal, is to always, my intent relates to community impact, is to try to place BCBAs in positions where we typically have not been, or in conversations or anywhere. It should always be have input from, one of us.
Right. Well, we think
so we haven't, highlighted, being on the news. Typically, like you were saying, it typically is maybe a clinical psychologist that, when something happens, they have the expertise coming from the traditional, mental health professional, psychologist, or a social worker. I was like, okay, well, why aren't we part of that conversation as well?
No, we appreciate that.
Why aren't we in that space as well?
Yeah, thank you so much for doing that. I appreciate that very much, and I'm sure the rest of us will at some point, because we need to put ourselves out there. We do have a lot of content expertise. I think over my career over the past 20, 25 years, we've become a little more prominent. We've learned how to play in the sandbox a little bit better with other professionals, and I agree. So thank you for putting us out there and putting a good expert face to the BCBA world. So I know we talked about your public speaking and speaking engagements. Tell us a little bit about that. It seems like you're pretty active in sort of mentoring and leadership, trying to bring up younger professionals up to a higher level, and you're pretty active in public speaking. So tell us a little bit about your work there.
Yeah, so I've been at several conferences, panelists. So there's the Black Women in ABA Appreciation Day that I did last year as a panelist. And then they also have a conference that's next month that's virtual, and I'll be a panelist in that one as well. Also a panelist for the Black Men in ABA. I was at their summit last year in Atlanta, and that was also a great opportunity. I really like doing panels because it's kind of more informal and you kind of can be able to feed off of each other, and it's less work preparing for like a full presentation.
Right.
So panels are really like my niche. But I've also done a presentation in Kenya as it relates to special education and autism. And so that was my first time actually presenting as opposed to just panels. And so, that's kind of the route that I'm going now, is disseminating more information, not just about, autism, but ABA in general, with the goal of kind of trying to detach ABA from just autism. And like I was saying, like putting ourselves as BCBAs or as ABA providers in different settings where people didn't know like who we are, what we did. It's like, okay, well, we know who you are, and we don't see you just as an autism provider. Like, we know that BCBAs could do like plenty of other things as well. And so,
would you expand a little bit on the international, the Kenya piece? How did that come about, and what was your experience like? I trust maybe you were prepared for something specific, and then maybe you got there and it looked a little different, or your content maybe had to be adapted a little bit. Tell us a little bit about that. That's remarkable. I mean, I can only imagine preparing here stateside and then getting to a certain international setting and being like, oh, wait a minute, maybe I didn't know exactly what I was preparing for.
Oh, no, I prepared to do a presentation. So there's a conference called DICES.
Okay.
And it's basically a conference that is organized by the special education community. It was my first time going, and last year it happened to be in Kenya. And so my presentation was related to the language barriers and the marginalization and the lack of providers, and the lack of sometimes people that speak different languages as it relates to getting services. And so, of course, I prepared I had a co-presenter as well. It was just two of us. And so she presented for 30 minutes and then I presented for 30 minutes. But it was an awesome experience to, of course, present in a different country, and then also be able to present around people that weren't like, it was not an ABA conference. It was like, teachers and professors around the country that was there. And so again, moving from like taking myself out of just straight ABA places and just strictly autism places, and disseminating like myself and these different projects and things like, oh, and we have one BCBA, and what is a BCBA? Like, where do you do again? And like getting other people the opportunity to like, hey, like, this is a field, and, we don't just do autism, and kind of inserting myself in these different spaces where I know that, our practice and what we do is very relevant.
So then this was specific to special education or specialized services in Kenya? Am I understanding that correctly?
No, it was just held in Kenya. So every year it's somewhere different.
I understand.
Last year, it was just there.
Okay, very well.
But everyone came from like around like different countries.
Gotcha.
Again, a lot of fun. I haven't had the opportunity to do that, but when I speak to people that have a chance to do that, it just feels like especially when you meet people from other countries, or if you look at the BACB and you look at the map of our distribution, the idea that you might see that there's one certified behavior analyst in India, and it's like that's a country of billions of people. How does that work? There's one of us looming around there. Good for them, plenty of opportunity. But yeah, it's always very interesting to see those differences from place to place. So what a cool experience. Well, believe it or not,
I have one last question for you. A quick one, small world one maybe. You said you got your degree from North Texas, right?
University of North Texas in Denton.
Was there the Kristen Farmer Autism Center there when you went there by chance?
So the program that I did was online.
Okay.
So I never actually made it to the campus.
I just bring that up because that was my first company was owned by her. So I knew her well, and I know she has a big footprint in North Texas. So just a University of North Texas. So a small little world. But
you didn't come across a Dr. C.J. Connard in your coursework, did you? By any chance?
Not that I remember.
Okay. Yeah, just we have a bit of a connection. So when you mentioned that, we were like, oh, I wonder. It is a small world. But yeah, I'm pretty sure that the folks we were mentioning had a hand in developing that online program through UNT. So yeah. Well, Dr. J, we've covered a lot of ground. Could you please take a couple more minutes to tell our audience where they can find you, assuming you want to be found, or to give one last pitch and promote your projects, however you want to disseminate that information?
Yeah, so I can be found on LinkedIn and Tranika Jefferson. So
yeah, thank you for
you type that into your LinkedIn, you will see me. I can be found on Instagram, Tranika J26, also coda.autism on Instagram, also behavioral.wellness on Instagram, and Tranika Jefferson on Facebook as well, CODA Autism Services on Facebook. And yeah, those are all my social media handles. Okay.
Well, thank you so much for your time today. Anything that our platform can ever help you out with, please feel free. Don't be shy. Reach out to us, and we're glad to collaborate with you. We really enjoyed our time. I didn't prepare again, Dan, for my 3 closing points, and you helped me out here. So
let's see. So, well, I kind of like her. I kind of like her 3 frustrations with ABA. I kind of like that. So maybe your child doesn't need 40 hours.
Maybe they need to be in school.
Maybe they need to be in school. Maybe you should think about your RBTs a little bit more and look at Ascent.
And
always analyze responsibly. Thank you so much, Dr. J.
Thank you so much.
Thank y'all. Bye.
Always analyze responsibly.
ABA on Tap is recorded live and unfiltered. We're done for today. You don't have to go home, but you can't stay here. See you next time.